computer. Make host.
Yes, sir. Yes, sir. Yes.
Okay. Now, can you see one slide? You should be able to see only one slide.
Yes, sir. Now it's proper, sir.
Okay. All right. Okay. So, good evening, everybody. I'm sorry that we've had a little bit of problems with the connectivity. Earlier, I was struggling with the YouTube connectivity and things like that. So, sorry for the delayed start. We are 5 minutes late, but hopefully we should be able to catch up. So today's topic is all about you. It's not about me. Anybody who doesn't have a 200-page notebook open, this is not worth it. So don't even waste your time, because this whole talk has been designed so that you should be able to draw things for me, okay? And that is the only way you will learn. It's all about physiology. It's very, very important that you understand how we are dealing with physiology. I'm going to deal with cardiac, thoracic. So it's going to be cardiac system, respiratory system, and esophageal, okay? So there's a lot to study. The thoracic guys may get a little bored because the first lot is predominantly cardiac. But I still feel that you must attend this and you must learn, because this is once in a lifetime chance to revise everything, where you know your fundamentals will become very clear. Okay, so everybody ready? Just say yes to me. Somebody say yes. Vikas, if you want, you say yes.
Yes, sir.
Yes, sir. Yes, sir.
Ready, sir.
Okay. For some reason, my headphones are not working. I don't know why. So I'll go on to the speaker. Okay. All right. So the first question that's going to come to you, the way this will be is I will ask you to draw the graph, and then we will discuss the graph and we'll try to understand what you need to draw. And that way you will understand the physiology much better. Okay. All right. So first question to you is, draw me a skeletal muscle action potential. Very simple question, very straightforward. I want you to tell me the 4 phases of the action potential. So first draw a diagram, and any diagram that you draw has got to have a horizontal axis, has got to have a vertical axis. So you need to tell me what's on the x-axis, what's on the y-axis, and then I want you to draw me a line showing me the graph, how it would look like. And I want you to mark out the various areas. So draw a skeletal muscle action potential. I want to know the phases of this action potential. I want to know which ion changes, what ion goes in and what ion comes out at each of these stages. And you have a minute to do that. And my suggestion is, on one page, just draw one graph so that you can start making notes below it. And for the next one, go to the next page. Don't try to be stingy. Okay, so just draw in the middle of the page or at the top of the page, draw your graph, and in below, try to make some notes on what I tell you. Okay, so draw skeletal muscle action potential. Tell me yes when you finished, so I know what to do next. Yes or no? Hello? Am I relaying or not relaying? I can't seem to understand.
Sir, relaying, sir.
All right. Thanks. Yes or no? Shall I move on or no? Nobody's saying yes as yet. All right. So this is a skeletal muscle action potential. You got to remember that the activity starts at minus 70. So you got to draw an x-axis, which is time in seconds. The y-axis is going to be membrane potential. And the action potential starts from minus 70. So it doesn't start from 0. So on that graph, look carefully where the 0 is. 0 is very important. And the stimulus when it happens, so resting membrane potential is minus 70. And when the stimulus happens, that's when the action potential starts. That is when the sodium channel opens. And as the sodium channel charges start to enter into the cell, the negativity of the cell changes to positivity. And it creates an upward swing, which is called a depolarization. And depolarization is because of sodium entering into that cell. And then once the sodium starts to enter, once the sodium channel gets blocked at around plus 30, the potassium channel opens and the potassium channel starts to leave the cell. So intracellular, it goes to extracellular. And that phase is called as repolarization, okay? And because repolarization happens, repolarization continues till a phase beyond minus 70. And look at the time in milliseconds, and that continues for almost about 380 milliseconds. And then you come back to resting membrane potential. So there is a phase called as after hyperpolarization, okay? So these are the thresholds that you have to remember. So resting membrane potential, depolarization, repolarization, and hyperpolarization. If you've written all 4 correctly, then you get 1 full mark. If anything is missing, then you lose marks. Okay, it's up to you how you want to give yourself marks. And in a skeletal muscle, there are 3 phases. One is called as a latent period, which is at the time of the resting membrane potential. Then there is a period of contraction right up to the apex of the depolarization. And then from the apex of the depolarization to repolarization and hyperpolarization, it's called as period of relaxation. And at this point in the period of relaxation, if a new stimulus comes, it may or may not generate the next action potential. Did this make sense?
Yes, sir.
Okay, good. Now tell me, what is this? What is this graph in front of you? What is happening in the graph? Explain to me. 2 lines you have to put. First, you have to diagnose what is this action potential. Not action potential, sorry. This is not action potential. You have to diagnose what is happening. And then the second line, you have to tell me what exactly is, there are multiple red arrows that are there. And there is a blue line. What is the representation of the red arrow and what is the representation of the blue line?
Is it plane of force stimulation which is showing?
No. Write down your answer.
Okay.
The problem is, if too many people talk, then we can't have a conversation. That's why, unfortunately, I would love to do it one-to-one and ask you questions, but there's a lot of knowledge here. So I want to make sure we get it across and we don't have cross communication. So preferably write down your answer, and when you finish writing, you tell me, yes, sir, we have finished.
Yes, sir.
Okay, all right. This is tetany actually, okay? This is tetany. What's happening is that the muscle has gone into a state of spasm, seen in tetanus, all right? The muscle has gone into a state of spasm and repeated stimulations are continuing to plateau the polarization. Can you see that? So for it to repolarize, it's taking a very, very long time. So the muscle is continuing to be in spasm and not allowed to go into the relaxation phase. And this is because the tetanus virus creates a toxin which blocks the release of which blocks the opening of the potassium channel. Okay, so the intracellular potassium cannot come out. And that is why the muscle continues to stay in a state of contraction. Did you understand that? That is why graphs are very important. You must learn to see a graph and understand what is the language behind the graph. It's very, very, very important. So it is, graphs are probably the best way to learn what is happening in physiology. But the problem is you must know the underlying story behind the graph. That is the most important thing. Okay, so we've finished. This is just the start. I wanted to get you warmed up to show you how this session will go. Okay, are you guys happy with this session? Are you learning something new or no?
Yes, sir.
Okay, good. So
Yes,
now,
sir.
because you have learned something about the skeletal muscle, tell me the same thing about the cardiac muscle. Next page, okay? Please draw on the next page. And this book must become your friend for the rest of your life. Again, it's very important to do x-axis. It's very important to do y-axis. I need to know the x-axis. I need to know the y-axis. And then the line must come. Happy, not happy?
Yes, sir.
Okay, I've drawn the curve for you. I've drawn the curve for you, but I want you to write down in your book what is 1, 2, 3, 4, 5, and 6. And I also want you to write down what is the name for phase 0, phase 1, phase 2, phase 3, and phase 4. It's a very long question, but this is the basis of all further discussions, okay? So I'm going in a sequence because my next questions are going to come on the basis of this. If you understand what is happening here, then the further physiology will become easy. So the question is, what is 1, 2, and you have to write down in your book, 1, 2, 3, 4, 5, and 6. I marked out some things. And also I want you to explain what is phase 0, phase 1, phase 2, phase 3, and phase 4. And the thoracic people don't think that you don't need to know this because the patient is in front of you. And when you are going to try and treat somebody in the ICU, you must understand cardiac physiology. It's very, very important to understand cardiac physiology. So learning this will make you a better clinician. Not learning, but re-remembering this. A lot of us have forgotten. Somebody say yes when you've finished, okay? So I will move on to the next one. This is a very important lecture for you guys, okay? You must benefit from it. Yes or no? And anybody who's on a mobile phone should preferably log on to a laptop, because just watching it lying down on a table, on a bed, will not help you with this lecture. This particular lecture works only when you interact with me. Otherwise, it'll become very boring for you. So if you are on a mobile phone just casually watching it, my suggestion is log off. It's not worth it. Until and unless you draw what I'm asking you to draw, you will not learn the concept behind it. Okay, yes or no? Come on, guys, quickly.
Yes, sir.
Yes, done.
Okay, so this is the graph. So let me just explain to you and I'll give you the answer also in a minute. So the phases of a cardiac cycle, it's quite important. The cardiac action muscle potential, the phases are initial rapid depolarization, followed by a rapid repolarization, followed by a slow repolarization, followed by a rapid repolarization. Okay, phase 4 is the resting membrane potential of the ventricular muscle is about 90 millivolts. Okay, so what happens in a myocardial action potential is in phase 0, there is initial rapid depolarization, rapid increase in sodium permeability. Okay, so phase 0 is initial rapid depolarization, rapid increase in sodium permeability. Sodium moves into the cell. Then there's a rapid repolarization, which means there's a rapid decrease in sodium permeability, a small increase in potassium permeability. Don't worry, the graph will come back. I'll show it to you again. The phase 2 is called a slow repolarization, where there's a plateau effect due to inward movement of calcium. So in a skeletal muscle, there was sodium and potassium. In a cardiac muscle, there's an effect of calcium. This is important to remember. So the slow repolarization phase is caused by the calcium, which causes the plateau. The plateau lasts for about 200 milliseconds, okay, which is a long time. 200 milliseconds is a long time in an action potential. The phase 3 is rapid repolarization, and repolarization means the negative becoming positive and the positive becoming negative. Okay, depolarization means negative becomes positive, and a repolarization, the positive is becoming negative. So in a rapid repolarization, suddenly there is increase in potassium permeability. So first there was sodium, then there was calcium, and now there is potassium. And potassium is starting to move into the cell, and the sodium channels are closing down. Is it making sense? So the negativity is coming back. You're dropping from a positive to a negative because things are moving from in the cell to out of the cell. And phase 4 is the resting membrane potential of the ventricular muscle, which is about 90 millivolts. Okay, and the SA node and the conducting systems do not have a resting membrane potential, which means that they are constantly depolarizing. So they keep firing regularly, whereas a cardiac muscle, the muscle part of a heart, has a resting membrane potential. Okay, so there is a excitation phase and there's a relaxation phase. Okay, so that is important to understand, and I'll tell you the significance of that last statement in a minute when I show you the graph after the next one. So this is the graph I want you to understand. Did you understand this? So first one is sodium going out. The second one is calcium going out. Sodium closing, calcium going out. Potassium is slowly starting to come in. The third one is potassium coming in dramatically. So that causes that positivity to go down. And then the fourth one is a resting membrane potential, which is because of leaky potassium channels. Did this make sense or no? The important thing in this chart is to understand that there is the blue under the curve. The blue under the curve is called as absolute refractory period, which means a second action potential cannot be initiated. So you cannot have a second potential being initiated in the middle of this. Yeah? Did that make sense? Yes or no? Good. So now my next question to you is, if I have shown you how does a cardiac muscle form an action potential, I want you to draw on a next page. And I've told you that the SA node does not have a does not have an area where it will does not have a resting membrane potential. So now draw me the propagation of a cardiac impulse. Propagation of a cardiac impulse, which means starting with the SA node, show me what happens after SA node, show me the atrial muscle, show me the AV node, show me the bundle of His, show me the Purkinje fibers, and then show me a ventricular muscle. So each one of these should fall one below the other. Did you understand what I said? Action potential of an SA node. The moment the SA node fires, what happens to the atrial muscle? So draw an action potential for the atrial muscle just below the SA node. Below that, draw me AV node, because as the potential is moving from SA, it goes to AV. So SA fires, atrial muscle contracts, action potential reaches AV node. The whole thing then goes to bundle branch, to the bundle of His. From there, it goes to the Purkinje fibers, and then the ventricle contract. So I want you to draw me a sequence of this. One below the other or one on top of the other, I don't mind. This is extremely important to understand how does a heart muscle fire. I'll give you two clues. One is that the SA node does not have a resting membrane potential, and the AV node does not have a resting membrane potential. Everything else has a resting membrane potential. Or everything else has a latent period or a plateau. So the SA node does not have a plateau, and the AV node does not have a plateau, but everything else has a plateau. I hope you understood the question. Frequently asked on a table viva in the FRCS for sure. Trace me from SA node to the ventricle, but in terms of action potential. Is it making sense, the question, or is it not making sense? Somebody give me a feedback, guys.
It is making sense, sir. Definitely.
The other 42 on the group, are they understanding what is the question or not?
Yes, sir.
So trace me SA node to the ventricular muscle. Okay, this is the answer. Okay, the key thing to this graph, what you have to understand is, one, I told you that the SA node does not have a plateau. The AV node does not have a plateau. Okay, the bundle of His has a very, very low plateau. But most important is you have to look from on the x-axis. Look at the x-axis. So the first activity that starts at the SA node. And whenever you draw this one on top of the other, you have to show movements along the x-axis. So it is tangentially going forwards along the x-axis. Did you realize that? That is the important thing I want you to understand. That this is starting here, but this is moving along the x-axis. The starting point is moving along the x-axis. If you haven't drawn it moving along an x-axis, it means you have not understood conduction of a action potential. So what is happening is there is conduction happening from SA node. So on the x-axis, SA node will start at one point, and then in time, as you move along the x-axis, it will go to atrial muscle, it will go to AV node, it will go to bundle of His, it will go to the Purkinje fibers, and then the whole ventricular muscle will contract. Did you understand this concept which I just told you? Yes or no?
Yes.
Yes.
Is exceedingly important. This is the diagram which tells you how is the conduction in a myocardial, in the heart. So you have to draw it at an oblique line. It's exactly how you would see in a manometry study of an esophagus. If I ask you to draw a manometry study of an esophagus, you cannot draw one below the other. It is always at a tangential because time is moving along here. So the bolus will start here and move along the time. So as the bolus moves down, it has to come tangentially. That is why this diagram is moving tangentially. There is a tangent to this diagram because your action potential is moving from one point of time to another point of time. And so you can then understand that SA node is giving you atrial muscle, is giving you AV node, is going to the bundle of his, is going to the Purkinje fibers, and eventually it's going to the myocardium, to the ventricle. Okay?
Sir, can I ask a question?
Yeah, you can if you want to. But my suggestion is we try and keep it very basic rather than try to dig into it all. Yeah, go ahead, ask the question.
I just wanted to know if you need to know the exact shapes of the...
Just not each shape you don't need to know. If Purkinje fibers, ventricular muscle and atrial muscle is like a myocardial action potential, that's okay. So you don't need to know the difference in the thing. But the SN node and the AV node should be different. Did you understand that?
Okay.
But these are all, it doesn't matter. In individual muscle, the plateau doesn't matter. But what you do need to know is that SA node and AV node are different from the rest. So the shape of all of this doesn't matter as long as it looks like a cardiac muscle action potential. Okay?
Thank you. Yeah, thank you.
That is why I started with a skeletal muscle, showed you a cardiac muscle, and showed you how the calcium channels give you the plateau. And so as long as you show me a plateau in all of them, it doesn't matter. But SA node and AV node should not have a plateau. That is the difference in this graph. Okay? Is it making sense? Are you learning?
Yes, sir. Yes, definitely. Now I understand. Thank you.
Good. Okay, thank you. My next question is, please, for the full mark, describe Starling Law. That's number one. And number two, please draw a diagram which represents Starling Law. First, I want you to write down what do you mean by Starling's law. And then for the next mark, you have to tell me, you have to draw a diagram of Starling's law. And thoracic guys, please bear with this. This is very important even for you. Okay, don't think that this is cardiac and you don't need to know this. It's good to know this physiology because everything else that I'm going to discuss next is all related to ICU. So it's important. Tell me what is Starling's law, and then draw me a diagram of the Starling's law. How will you represent it as a picture? Yeah? Okay, so while you are drawing the diagram, let me tell you what is Starling's law. Starling law is that the energy of contraction of a cardiac muscle fiber is a function of the initial length of the muscle fiber. Okay, so it's very, very, very important. This is the key to the whole contraction of the cardiac muscle and why in cardiomyopathy you get poor ejection fraction. So the concept of ejection fraction comes from the Starling's law. The Starling law says that the energy of contraction of a cardiac muscle fiber is the function of initial length of the muscle fiber. So the greater the stretch of the ventricle in diastole, greater will be the stroke volume. So the initial length has to be contracted, and then when you stretch it, there comes to a point where it cannot go beyond the Starling law, but maximum point of Starling law will give you a very good contraction. So greater the stretch of the ventricle in diastole, greater the stroke volume. Stroke volume means the amount of blood which is coming out. So more blood in the heart, that is higher the end diastolic volume, the more the sarcomeres are stretched. Sarcomeres are units of cardiac muscles. So more blood in the heart, which is higher the end diastolic volume, more sarcomeres are stretched. Up to a point, increasing the venous return increases the force that the heart muscle can exert. So there is a critical point in which you can stretch. Beyond the critical point, further increase in the amount of blood will actually decrease the force that the heart muscle can exert. So that is the key thing about Starling law, is the initial muscle fiber strength is important. Initial muscle fiber distance is important. And then the stretch that you can do up to a certain point, that gives you a fantastic stroke volume. The moment you go beyond the Starling's law, then you are actually losing the power of the muscle to contract. That is why cardiomyopathy is not a good thing for the heart. A diastolic cardiomyopathy is not a good thing for the heart. The stretch of a heart muscle happens in diastole when there is filling of the heart muscle. So that is why the stretch of a cardiac muscle can only go up to a certain point, and the moment it goes beyond it, it is not good. Ejection fraction will drop because the force with which the heart muscle will contract will drop. Did you understand what I just said?
Yes.
Is it absolutely clear?
Yes, yes.
Yes, sir.
Now draw the diagram, because the diagram is going to represent everything that I said. So I want an x-axis, I want a y-axis. On the x-axis, I'm helping you along. On the x-axis, I want you to show me end diastolic volume. So you increasing end diastolic volume will have an effect on stroke volume. So on the y-axis, it has got to be stroke volume. So end diastolic volume, which is the initial length of a cardiac muscle fiber, is on the x-axis. And stroke volume, which is the energy of contraction, is on the y-axis. And now draw me a normal Starling's law with a heart muscle, and more importantly, above it, show me what happens with sympathetic stimulation, and below it, show me what happens with the failing heart. In the same graph, draw normal Starling's law. Above it, draw what happens when you stimulate the sympathetic stimulation of the heart. And below it, show me what happens when there's a failing heart. Did you understand the question? Shall I show you or shall I wait? Yes or no? Somebody has to say yes for me to go on.
Yes, sir.
Yes, sir.
Okay. So the answer to this is this graph. Okay.
Yes, sir.
Okay. So now look at this graph and try to listen to everything. Try to recollect everything that I said. So the x-axis has got to be end diastolic volume, which is the initial length of the muscle fiber. So you start with here. You can look at the normal one first. On the y-axis is stroke volume, which is the energy of contraction. So the Starling law states that the initial length of the muscle fiber, you can keep stretching it, and as you stretch it, the stroke volume keeps going up up to a certain point, and beyond that point, it will fail. Okay, so it does not help it anymore. So this is the Starling law. This curve is the Starling's law. What happens in a failing myocardium is you stretch it and it cannot generate a stroke volume. At a much higher end diastolic volume, will you get the same stroke volume? So the failing heart will come below and a sympathetic stimulation will move the Starling's law higher. Okay, so with the same amount of stretch, when you stimulate the sympathetic stimulation of the heart using an inotrope, then you are getting a higher stroke volume. Have you understood this concept? You're really getting a rapidly beating heart and fantastic contraction of the heart. Did this make sense? Yes or no?
Sir, I have a doubt here. If it is possible for me to ask.
Yeah, you can, but my suggestion is first let's get all concepts clear, and then all doubts we can discuss at the end, because there are over 200 slides. And if everybody keeps asking question about physiology,
Okay, sure.
these are facts. I can't change these facts. So just stay with
Alright.
them. And I think I'm explaining it pretty clearly, point wise. So preferably, I would prefer if you don't ask questions at this stage. But if you have something very urgent, which is wrong, which I'm stating is wrong, then please go ahead and ask.
Sir, I won't say it's wrong, but just I had the concept of sympathetic stimulation would reduce the end diastolic filling. So shouldn't it technically reduce the output?
No, it actually increases the stimulation. This is the basis of Starling's law. Okay, it increases the contractility of the heart. So we are not saying that it will affect the end diastolic volume. We are talking about the stroke volume. This diagram just represents the stroke volume. So what is happening is the effect on the stroke volume. And this Starling's law, sympathetic stimulation is directly representing the stroke volume rather than the end diastolic volume. We're not talking about this at the moment. We're talking about the effect of sympathetic stimulation on the stroke volume. Okay?
Okay, sir. Okay, thank you, sir.
All right. So later on, sit with these graphs and try to understand every concept. They are, it's very difficult to just pick up a snapshot and show you, but things are different in context of the conversation. But here, we are only representing stroke volume. We want to see what is the effect of Starling's law on stroke volume. Okay. All right. Okay. Let's get to the next question. Please identify, give me numbers on 1, 2, 3, 4, 5, and 6. It is very important, these numbers, because everything that we discuss from here forth is directly related to these numbers. I want to know what is 1, 2, 3, 4, 5, and 6. I want you, and some numbers have a denominator, and some numbers only have a numerator. So I want you to point out which has a numerator and denominator, and which has only a numerator. When I'm saying this is, some numbers have systole and diastole, whereas some areas have only systole. Again, this concept is very important to understand. So that is why I'm giving you clues on this.
Yes, sir.
Okay. This is easy. Everybody should be able to answer this. But this is very important because these numbers have to be remembered when I talk about things next. Okay, these are the numbers, okay? So aorta has 120 over 80. Pulmonary artery is 25 over 15. Right ventricle is 25 over 0 to 4. Left ventricle is 120 over 0 to 10. The right atrium is 0 to 4. And the left atrium is 5 to 10. Okay? Is it clear? Okay. So now, these are facts. I can't change these. These are just stay with these facts. So now, I'm sorry, the last thing has just come up. Listen to the various steps of a cardiac cycle. I want you to tell me there is stage 1, stage 2, stage 3, and stage 4. And as you can see in front of you, stage 4 has got A, B, and C. So tell me, what is stage 1? What is stage 2? Or phase 1, phase 2. Phase 2 has got 2 phases, 2A and 2B. Phase 3, phase 4A, 4B, 4C. I'm afraid, I'm sorry, the last part has not got animated. Write them down, write down these answers. So start with systole and tell me what happens in phase 1 to the valves. Which valve opens which? So the first thing that happens is contraction, where the mitral and tricuspid valve close. The next phase, which is phase 2A and 2B, is ejection, when the aortic and pulmonary valves open. You then move into diastole, where you enter the third phase called as relaxation, where the aortic and pulmonary valve close. And then there is a filling, which is 4A, B, and C, where the mitral and tricuspid valve opens. This is a very important slide. This is the key to all understanding of physiology of the heart. So I will go through this again. Starts with systole, contraction, mitral and tricuspid valve closes. Ejection, which is stage 2A and B, aortic and pulmonary valves open. Diastole, which is relaxation, stage 3, aortic and pulmonary valve close. And then fourth is filling, which is mitral and tricuspid valves open. Did this make sense so far?
Yes, sir.
I'm
Yes,
going to
sir.
go through each one of this in more detail, okay? But this is worth learning now, okay? I'm trying to teach you everything. So any cardiac cycle starts with 4C. Whenever you are going to draw me a cardiac cycle in a graph, you cannot start with 1. It does not start with 1. It starts with 4C, which is atrial systole. A cardiac cycle starts with 4C, atrial systole. SA node depolarizes. Atrial muscle contracts. Blood flows through the AV valve to the ventricles. AV is atrioventricular valves. Okay, you've got to understand that, mitral and tricuspid. And that completes the last 15% of ventricular filling. So whenever you draw me a graph of cardiac cycle, you have to start with atrial systole, which is 4C. Once you move from there, you move to phase 1. Phase 1 is called as isovolumetric contraction of the ventricles. The atrioventricular valves have closed. The tricuspid and mitral have closed. The aortic and the pulmonary valves have opened. And the volume of the blood in the heart remains constant because the AV valve has closed. So the pressure increases in the heart just as the AV valves are about to open. So this is called as isovolumetric contraction. Volume of the blood in the heart remains constant as the pressure rapidly increases. So mitral is closed, the tricuspid is closed, aortic and pulmonary are still closed, and the myocardium has suddenly started to contract. So the volume remains the same, but the pressure dramatically starts to rise. The moment the pressure starts to rise, you get into a phase called as 2A, which is called as ejection. Ejection phase happens when the pressure in the ventricle exceeds the pressure in the aorta and the pulmonary artery. When the pressure in the ventricle exceeds the pressure in the aorta and the pulmonary artery, it forces the valves to open. We're talking about aortic and pulmonary valves. They open, as a result of which blood gets ejected into the aorta and pulmonary artery. So contraction of the myocardium, which is isovolumetric contraction, increases the pressure. The pressure in the ventricle goes above the pressure in the pulmonary and the aorta. And because of the increase in pressure, the valves get forced open. The myocardial contraction continues, and it ejects the blood from the ventricle into the aorta and the pulmonary artery. Remember, one is left side, one is right side. So we are continuing to talk about the left and right side. The moment the ejection starts, you get into phase 2B of the ejection, which is continuing to eject, where the aortic and pulmonary pressures equalize with the ventricle. So now the pressure is equal between the aorta and the ventricle and the pulmonary artery and the right ventricle. So aorta is left, pulmonary artery right. Moment that equalization of the pressure happens, you move into phase 3, which is called as diastolic relaxation. Diastolic relaxation means the volume is remaining the same, but the myocardial muscle is relaxing because the AV valves have not opened. The mitral and tricuspid have not opened as yet, and the muscle has started to relax. That is called as isovolumetric relaxation. At this stage, the ventricular pressure starts to form, and this causes, the relaxation causes the aortic and pulmonary valves to close. So there is a closure of the aortic and pulmonary valves. That is phase 3, isovolumetric relaxation of the heart, causing a drop in the pressure and pulmonary and aortic valves shutting down. The moment the pulmonary and the aortic valves shut down, you enter into phase 4A. In 4A, there is filling, it's called the filling phase of diastole, where now the aortic and the pulmonary valves have shut down, but the mitral and the tricuspid valve open up. The moment the mitral and tricuspid valve open, there is the process that is called as passive ventricular filling. Passive ventricular filling is then followed by rapid ventricular filling. The low pressures due to the low atrial pressures due to suction effect results in a rapid filling. Okay, so the ventricular suddenly starts to relax, and then it overcomes the atrial pressure and then just sucks all the blood. Initially, it starts as a slow filling as the valves are opening, and then because the ventricle relaxes, the pressure becomes negative and pulls all the blood out from the atrium across the mitral and tricuspid valve into the ventricle. And this phase is called as rapid filling, rapid ventricular filling. The moment rapid ventricular filling starts and it goes through the cycle, you enter into phase 4B. The 4B is now the myocardium is relaxing. The volume is starting to go up. The pressure is increasing. Hence, there is a decline in the rate of filling as the atrial volume increases. And finally, the active atrial contraction begins again and moves you into phase 4C, which is the start of the next cardiac cycle. Did this explanation make sense or not?
Yes.
I went slowly enough, but still I had to talk to you through the whole thing. And if you don't know, then you cannot learn it on a lecture like this. It will come later on when you go back and revise this graph, okay? Revise this talk. But everything that I've told you is sequential. So phase 4C, phase 1, phase 2A, phase 2B, phase 3, phase 4A, phase 4B, and then move on to 4C, which is the start of the next cycle. So now I want you to tell me, what is ejection fraction? Quickly write down, what is ejection fraction? What is your understanding of the ejection fraction? During phase 3, the ventricle ejects about 60% of its volume. It is the 60% of the volume of ejection that is called as ejection fraction. That is what is the explanation of ejection fraction. Now, below this explanation, I want you to write what is the formula for calculating ejection fraction. I have done the explanation first before I asked you the graph, because it's important that you revise the explanation and then the graph will start to become easier. Otherwise, you will never understand the graph.
Yes, done.
Okay. So ejection fraction, the formula that you do is stroke volume divided by left ventricular end diastolic volume. This is the formula, okay? So it's quite self-explanatory if you have understood the previous part of my lecture. So let's go on to the next thing about ejection fraction. During phase 3, the ventricles are topped by up to 15% at rest, but more at higher heart rates. Failure of atrial contraction at higher heart rates, that is fast AF, is a problem because you lose out on the 15% of the topping up, okay? That is quite important in an ejection fraction. So again, the Starling law comes into
charge nahi hai
left ventricular end. Dr. Mehta, just switch
मेरे पास
off
वो
microphone.
नहीं मिल रहा मुझे
Dr. Mehta, switch off.
क्या होता है
Where was I? I lost my connection. What was I saying?
Loss of ejection fraction because of catheter.
So the concept here is the Starling's law is very important because the force of contraction of a myocardium depends on the amount of stretch of the ventricle. And if in a fast AF, because it's happening so fast, there is no time for the atrial systole to fill the myocardium. So there is no time for the ventricle to stretch to its maximum capacity. Hence, you lose almost 15% volume. As a result of that, a fast AF may actually result in reduced stroke volume because the first pressure that you're applying on the cardiac myocardium is reduced. Okay, Starling's law. This is why Starling's law is important. You must understand the first concept of Starling's law before you understand anything else. Okay. Okay. Now, quickly, I want to tell you about the heart sounds. Listen to this, or actually, I want you to write down. Tell me, why does the first heart sound occur? Write down in your book.
Yes, sir.
Happens because of the closure of the atrioventricular valves, okay? Bicuspid, mitral and tricuspid. Is best heard at the apex, and it's louder in mitral stenosis, in hyperdynamic circulation and tachycardia, okay? The second heart sound, why does that happen? Why do you listen to a second heart sound? What structure is closing? One thing you've understood, it usually happens because of the closure of the structure, the snap. So why does the second heart sound happen? Yes or no?
Yes.
Yes,
Yes,
sir.
Because of the closure of the aortic and the pulmonary valves, okay? And there is a concept of physiological splitting of the aortic and the pulmonary valve, which is A2P2, and we'll talk about that a bit later, okay? So this is due to prolongation of ventricular ejection periods during inspiration, resulting from increased stroke volume, secondary to increased venous return. Okay, just stay with this information. I'm giving this information for a specific reason, because I am coming to a graph in a minute. Tell me, why does the third heart sound happen? When do you hear a third heart sound? In terms of physiology of a myocardium, why does the third heart sound happen? Are you writing this down or no?
Yes, writing.
Yes, sir.
Done.
Third heart sound happens due to rapid ventricular filling, okay? But best heard in children, all right? Why does the fourth heart sound happen?
Yes, sir.
Okay, it happens because of ventricular distension or a stiff ventricle caused by forceful atrial contraction. It usually indicates ventricular hypertrophy or heart failure. Okay, so now, having given you the background knowledge, now this is not any lecture on physiology. This is a lecture on graphs. I want you to understand graphs. So this is what I want you to reach to. I want you to be able to draw the whole cardiac cycle from start to end. So my question to you will be, tell me, draw me a cardiac cycle telling me the pressures in the atrium, ventricle, and aorta. So I want you to draw the x-axis, which is time, and the time will start from 0 to 0.8, and the 0 comes a little to the side because we have to start with 4C. Do not start with 1, start with 4C. So move your x-axis to the right on the x-axis. Don't start with 0 of the y-axis and 0 of the x-axis meeting. So 0 starts away from the crossing of the two axes. Go up to 0.8 milliseconds. Okay, so 0.8 seconds, not millisecond, 0.8 seconds. On the y-axis, I want you to put pressure from 0 to 120. We are drawing a normal cardiac cycle. And now draw me atrial systole, ventricular systole, and ventricular diastole. So first draw me the ventricular graph. On the ventricular graph, I want you to superimpose the atrial graph. And on the ventricular graph, I want you to superimpose the aortic pressure change. That is why I showed you what was the pressure in the aorta. Please draw this. Take your time. This is not easy. Actually, it is very easy if you understand the concepts which I just explained to you. X-axis is time. Y-axis is pressure. Time moves from 0 to 0.8. Y-axis moves from 0 to 120. And the first diagram that you're going to draw is ventricular pressure. I want you to show me what happens in the ventricle. Keep going. I'm just trying to look back on something. And when you finish, please tell me. So I want you to go through these things. You must draw me phase 4C, phase 1, phase 2 when the ejection is happening, phase 2B when there is equalization of the aortic and pulmonary pressures. I want to see what happens in a diastolic relaxation, which is isovolumetric relaxation. I want to know what happens in the atrium in the phase 4A, 4B. Okay, are you ready?
Yes, sir.
Fantastic. So this is the answer. Now you have to draw it in this way. The zeros of the two charts never cross. Okay. The ventricular goes from 0 to 120. The time goes from 0 to 0.8. And first draw the ventricular pressure. The first little bump is because of atrial systole. And then this rise of pressure happens. From 0, the ventricular pressure rises all the way up to 120. At 120, what will happen is your ventricular pressure overcomes the atrial pressure, and suddenly the valves open and the blood starts to pour out. When the blood starts to pour out, your diastole, your pressure in the ventricular dramatically drops, and then you come down to 0. That's ventricular pressure. As opposed to that, you have to draw me the atrial pressure, which starts from 0 and goes up to about 15 and then drops down again. Okay. And this has to be correlated with aortic pressure. And we said the aortic pressure lies between 80 to 120. So 80 to 120. And then this little snap happening because of the projection of the valves. And then the aortic pressure comes down. Okay. Have you been able to draw this diagram? Did you understand what you drew or you did not understand?
Yes, understood.
It's very, very, very important.
Yes.
This, please look carefully at this diagram. I don't mind you spending a few more minutes on this diagram, but look carefully. Try to understand what is exactly happening at each phase. Phase 4C, phase 1, phase 2, 2A, 2B, 3, and then 4. That is how you have to count. It has to go all the way through to phase 4. And your diastole to systole has to be 0 to 0.8 second. Okay. So it has to go all the way from systole to diastole, 0.8 seconds. This timing is also important because now we will come to ECGs and heart sounds and things like that. Did this make sense or no? Guys, tell me, give me a feedback. I need to understand whether you have understood or not.
Yes, we are going in sequence.
Okay. Anybody else wants to quickly give me a feedback? Is it making sense or no?
Yes, sir.
Yes, sir.
We need to go
Yes,
back
sir.
again and again and get.
Yeah. It's okay to not know it. It's okay to be confused. And that is why I'm not taking questions at the moment. Because your concepts may or may not be clear. So your question may confuse everybody. And that's why I'm trying to just stick to the chart. Okay, stick to the chart. Understand exactly what's happening here. Did it make sense so far?
Yes, sir.
Yes.
Give me the next answer. You have now understood what is happening to the myocardium. Draw me what do you think the chart will look like for left heart volume. Okay, how does the volume increase or decrease? So keep the x-axis same, 0 to 0.8. But tell me in terms of volume. So now we're talking about ejection fraction and how the ejection fraction drops. So what is the left ventricular volume? How does it drop? So from 40 to 120 mils, show me how the volume will drop. And if you don't understand it, it's okay. You'll have to sit back and think afterwards after I finish the lecture. But just draw a diagram, some sort of a diagram. What do you think will happen to the volume? The left heart volume. So what's happening is the ventricle is completely full, and when the diastole starts, the volume will go down in the left heart. Obviously, because you are ejecting things into the aorta. And because the volume, then you enter into the diastolic phase, the volume will start to come up again. Okay, so this is what is the explanation of this. So this volume, and this is the last 15% is here. When I said that the atrial contraction adds 15% to the volume. So this is 85% and that's 15%. So the volume at the opening of the aortic and the pulmonary valve will start to drop dramatically. The left ventricular volume, because obviously you're ejecting. And then the moment you enter into the diastolic phase, after the atrial and ventricular valve has closed and the mitral and tricuspid valve have opened, the volume will start to increase. And then the atria will contract and it will add an extra 15% to the volume. Did you understand that? So this is slow, this is relaxation and the volume is slowly filling. Then it gets into the rapid filling because of the negative suction effect created by the contracting myocardium. And then, sorry, can you see my arrow? So this is the slow diastolic filling, and then it gets into the rapid filling, and then the atrial contraction adds this little bump of 15%. Okay, did it make sense what I just showed you? Yes or no, guys? Some feedback.
Yes, sir.
Yes, sir.
Yes, sir. Take your time afterwards, okay? Because on the live lecture, I cannot. Okay, so tell me what happens to the right heart pressure. Now, I want you to draw the same diagram. Go back here and have a look at this. I want you to draw the same diagram, 0 to 0.8 on the x-axis. But tell me, what is the pressure in the right ventricle? What is the pressure in the right atrium? And what is the pressure in the pulmonary artery? The same one, this was the left heart volume, left heart pressure. Okay, this is the left heart pressure. The same diagram. I want you to draw me the right heart pressure. What do you think will happen in the right heart? Take your time. This is very important. This next few slides are the key to everything. I'll give you the left heart in front of you. This is the left heart pressure that we have drawn. So now I want you to draw me the right heart pressure. I want to know what's happening in the right ventricle. I want to know what's happening in the right atrium. And I want to know what's happening in the pulmonary artery. Now I'll give you a clue. Time remains the same, 0 to 0.8. But the right heart pressure we know is lesser. So the y-axis of the graph will go from 0 to 25. Instead of 120, from 0 to 120, the y-axis will go from 0 to 25. Have you understood that?
Yes, sir. Yes, sir.
So any graph, you have to understand the x-axis and the y-axis. Very important. Yeah?
Yes, sir.
Okay. This is what happens in the right side of the heart. So in the right side of the heart, right ventricle, again, the pressure goes up, up, the valve open, and then the pressure starts, the ejection goes out, and the pressure starts to fall down. And then you enter into the phase of relaxation, where the pressure gradually will go down and then start to go up again. The same thing with the atria. This is the atrial contraction and then relaxation, and then the pressure goes down and draws. The same thing with the pulmonary artery. Okay, so if you have understood the left side pressures, then the right side pressures exactly mimic the left side pressures, because the same activity is happening, except that the myocardium on the right side is not as strong as the left side. So the pressure that it can generate is only from 0 to 25. Okay? Understood or no? And if you haven't, take your time afterwards. It's okay. Show me what happens in the right coronary artery and the left coronary artery. Just draw a random volume. Show me how the blood will flow in the left coronary artery and the right coronary artery. At what phase of the cycle is there maximum blood flow in the left and the right coronary artery? And this is where the concept of intra-aortic balloon pump comes in. You have to understand what phase does the heart get the maximum blood flow in the coronary artery.
Yes.
Can somebody tell me? You can tell me if somebody knows. In systole, diastole. Excellent, excellent. So now the next graph will make sense to you. Is that when the systole is happening, okay, the volume in the coronary artery goes dramatically down, and it waits till the aortic and the pulmonary valves close. When the aortic and the pulmonary valves close, that's the start of diastole. That's when the coronary blood flow is the most maximum, okay, in the right and the left side. Everything will eventually come together, so don't worry about it. Just stay with me on this at the moment, okay? So sorry about this graphics here. It's just become ECG. ECG, you have to, when you look at an ECG, you got to look at the heart rate, you got to look at the rhythm, disorders of conduction, size and muscle mass of the heart. You got to look for damage, electrolyte disturbance, and also look for pericardium. Now, this is not a lecture on ECG at the moment. All I want to know is normal what happens. Just PQRST at this stage. That's all I want you to concentrate on. So what do you think happens in an ECG when the cardiac cycle is going on. And I want you to draw a picture of an ECG with P, Q, R, S and label the timings in terms of milliseconds. How much time does it take for P? How much time does it take for PR? How much time does it take for QRS? And then up to T, because that will fall in with the cardiac cycle. I'll just help you out here. I'll just show you this. This is basic knowledge. This is something that you must have. So the P wave is because of atrial activation. The QRS complex is because of ventricular activation. And the T wave is because of ventricular recovery. Okay? And these are the timings that you need to remember. We'll talk about it when I do my ECG lecture. But what is the correlation of the ECG with the cardiac cycle? So where does the ECG lie and where does the heart sounds lie on the same cardiac cycle? So draw an x-axis with timing of 0 to 0.8 and tell me where is the first, second, third, and fourth heart sound, and how will the P, QRS, and T lie on a cardiac cycle. Is it making sense what I'm saying, or is it getting too complicated?
No, sir, it will make sense, sir.
Again, I'm not testing you on ECG. I'm testing you on where do you think the heart sounds and the QRS complex will lie with relation to a cardiac cycle. So again, draw 0 to 0.8. And on an axis of 0 to 0.8, I want you to draw me where do you think the P will lie, where will the QRS be, and where will the T be? This is the answer. Okay? So P, QRS, and then T. Ventricular relaxation, ventricular contraction, atrial contraction. Okay, atrial contraction, which is 4C, ventricular contraction, which is 2A and B, and then ventricular relaxation. Okay, stage 3 and 4. So this is where it is. And that's the first, second, and third and fourth heart sounds are usually beyond your this thing. Fourth is usually in a stiff ventricle. The third may be heard in a child, but 1 and 2 you must know where it lies. Yeah, the atrioventricular valves closing and the mitral and tricuspid closing. Okay, so now we put it all together in one picture. Now everything is together in one picture, and please take another paper and draw this whole graph as it is represented. Take 2 minutes and please look at the picture up that's on the screen and draw this again after we have understood the various concepts. Take 2 minutes. This is not easy. Take 3 minutes, 4 minutes, it doesn't matter. But whenever you're finished drawing all of these activities, tell me, sir, let's continue. This is very, very, very important. Okay? I'll be back in a couple of minutes. I want you to look at the picture and draw. Don't worry, this is all about education. It's not a test. So look at the picture and now draw everything with relation to all the facts that you've learned so far? Switch off your microphones at the moment because it's making noise. So I want you to draw the left heart pressures, looking at this spike, looking at the left ventricular thing, and there. I want you to draw the, tracing your atrial pressure. I want you to draw the aortic pressure. I want you to draw the left ventricular volume, how it drops and then slowly fills up, then rapidly fills up, then the atrial bump. Similarly, I want you to draw the right heart pressure. This is 4C. So there is that contraction of the atrium. Then there is contraction of the ventricle, opening of the valves, and then sudden drop in the pressure because the valves have opened and you are now ejecting. The valves have now closed, and once the valves have closed, then the relaxation of the muscle is happening, and then the pressure is dropping suddenly till it comes back to stage 4C. Same thing with the coronary blood flow. You have to show that the coronary blood flow is the highest in diastole. This is diastole, start of diastole, okay? And so coronary blood flow is immediately high and then slowly tapers down. The same thing will be represented on the right side as well. Left is the more important, oh, sorry. And then again, I want you to draw the heart sounds in relation to the to the activity in the heart. So that's your first heart sound, that's your second heart sound. As long as you can draw first and second, I'm happy. And then I want you to draw the P wave, which is because of atrial contraction. And then I want you to draw QRS, which is because of ventricular contraction. And then the T wave, which is because of ventricular relaxation. Okay. Now, did this make sense or no? Feedback time, guys, before we go ahead. This is absolutely vital. If you haven't finished drawing, we'll wait. It will not happen in one day. If you have not studied this before, you will not be able to redraw any of this. So take your time. I'm not worried about it. This is not an exam. But the next time you draw it, you must listen to my talk before. Stage 4C, 1, 2, 3, 4. And 2 is 2A and 2B. And 4 is 4A, B. And then C is the start of the cardiac cycle. Did that make sense or no? Bhaiya, feedback.
Yes, sir.
Yes, sir.
This is the key to the whole explanation. Okay? If you guys can master this chart, and it will not happen straight away, it takes time. Okay, if you guys can master this chart, there is nothing in cardiac physiology that you cannot explain. This chart is the most important thing. The problem is most of you come to this chart and you look at it in totality and you're completely lost. Until and unless you break this chart into various components, and before you start drawing, you have to understand 4C, 1, 2A, 2B, 3, and 4A, 4B. This chart makes no sense whatsoever. So that is why understanding this chart is exceedingly important to know the facts before you start drawing this chart. I cannot expect you to draw this chart until and unless you know what is happening. 4C, 1, 2A, 2B, 3, 4A, 4B. Yeah? Let me know when I can continue, if you're happy or you're not happy. Vikas, how is it going?
Very good, sir.
Is it making sense? I mean, you know it all. I know you guys know it all. But the thought process has to change, how the chart has to be interpreted. Yes or no? No? If you guys are too hassled by all this, tell me, I'm happy to stop, okay? I don't want to stress you guys out. But nobody said that this was going to be an easy chapter. Is there anything that I'm saying that is wrong or I'm confusing you?
No. We have drawn the chart now.
But did the chart suddenly make sense?
Yes, yes.
Let me know when I can continue, okay? It's important I continue.
Continue, sir.
Finish drawing.
Everybody's finished drawing?
Yes, sir.
I'm sorry if it is becoming too much for you guys, okay? Okay, now turn your page and please draw me jugular venous pressure. Draw it widely, okay? So every part becomes clear. Draw me a chart on jugular venous pressure. Say yes whenever you're ready.
Yes, sir.
Yes, sir.
Okay, so this is the chart of jugular venous pressure where I want to see three peaks, A, C, and V, and two troughs, which is X and Y. Okay, so let's go through this jugular venous pressure and try to understand what the hell is jugular venous pressure. So the A wave that you get, and I've kept it at the bottom for you to see it, the A wave is because of atrial systole. Okay, so usually the A wave is absent in atrial fibrillation. And there is something called as Cannon waves in complete heart block. We'll talk about abnormal things a bit later. Just at this moment, understand the A wave is because of atrial systole. Okay? Giant waves are seen in pulmonary hypertension, tricuspid, and pulmonary stenosis. Okay? Now, C wave happens because the tricuspid valve leaflet bulges into the right atrium during isovolumetric contraction. So when the tricuspid valve is closed and your ventricle starts to contract, the increase in the pressure of the right ventricle with a isovolumetric contraction causes the tricuspid valve to bulge into the right atrium. And when it bulges into the right atrium, it causes a peak because of the sudden bulge backwards of the tricuspid valve. And that is the explanation for the C wave. Okay? And it is synchronous with pulse wave in carotid artery. Okay? So you have to put one hand on the carotid artery and you have to look at the JVP, okay, or JVP tracing. And so what they're saying is when pulse wave in carotid artery happens because you're contracting, the ventricle is contracting, and because of the back pressure, there is a sudden bulge in the jugular venous pressure. The V wave that you're seeing is happening because there's a rise in the atrial pressure before the tricuspid valve opens. So the V wave, the tricuspid valve is closed and your atrial pressure is suddenly rising, and that is the explanation for the V wave. The X descent of a jugular venous pressure is because of tricuspid valve moving downwards during ventricular systole. So once that isovolumetric contraction has happened and the pulmonary valve is opened, suddenly the blood flows into the pulmonary artery. As a result of this flow, the tricuspid valve is pulled down into the right ventricle, and that causes a negative pressure in the right atrium, and that is represented by the X descent. And the Y descent is obviously because the tricuspid valve opens. The tricuspid valve opens, the right atrial pressure falls as the blood flows towards the right ventricle. Did this make sense?
Yes, sir.
Yeah, so you have to know each component. Why is the A? Why is the C there? Why is the V there? And what does the X represent? And what does the Y represent? So normal central venous pressure is 5 to 12 millimeters of mercury. A low CVP indicates hypovolemia and a high CVP indicates fluid overload. Okay? All right. Inaccurate CVP can be seen when there's disparity between functions of the right and the left ventricle, in right ventricular infarction, in pulmonary embolism, in left ventricular disease. So the filling pressure of the right heart may not reflect the filling pressure of the left heart. So normally you use the CVP as a surrogate marker to understand what is happening in the left atrium. It's very difficult to get to the left atrium. The left atrium is the most difficult one, which doesn't give you a chart. So you use the CVP, the right atrial pressure, as a surrogate marker for the left atrial pressure, because it's really the left atrial pressure that you want to know. That is real importance in clinical value. The problem is, if for right atrial pressure to represent the left atrial pressure, the circuit, the pulmonary circuit has to be normal. So you are assuming, because it's a low pressure circuit, the pulmonary circuit is a low pressure circuit. So you are assuming that if the pulmonary circuit is normal, then the right atrial pressure represents the left atrial pressure. But if there's any problem in the pulmonary circuit, like a pulmonary embolism or pulmonary hypertension or anything else, then the right atrial pressure does not represent the left atrial pressure. Or in a compromised patient, the right atrial pressure does not represent the left atrial pressure. In that situation, you have to put in a catheter into the right atrium, across the right ventricle, across the pulmonary valves, into the pulmonary artery, and blow up a balloon so that you occlude the pulmonary artery, so that the tip of the catheter now represents the left atrial pressure. And that is called as pulmonary capillary wedge pressure measurement. We'll talk more about it. Don't worry if you didn't understand what I just said. I'll show you a picture. So my next question to you is, can you please mark out the proximal lumens of a pulmonary artery catheter, which is also called as a Swan Ganz catheter. So enumerate 1, 2, 3, 4, 5. I'm giving you a clue. There are 5 lumens proximally which you need to identify. So tell me, what is 1, 2, 3, 4, 5? What do you think 5 lumens are needed on a Swan Ganz catheter or a pulmonary artery catheter? Just write down each one of them. What are the uses of 5? Why do you need 5 lumens on a pulmonary artery catheter? When you finished, you can tell me. Again, you get marks for everything that you get correct, okay? So please don't forget to mark yourself. So when you have a catheter, you've seen a central line catheter. So a Swan Ganz catheter is a longer catheter than a central line catheter, obviously, because it's got to travel across the heart into the pulmonary artery. And just like a central line catheter, you have 3 to 4 lumens. A Swan Ganz has 5 lumens or 5 proximal connections. I want you to tell me what are the 5 proximal connections. What possible things you can use it for? Write down 1, 2, 3, 4, 5. 5 things have to be written. Are you with me? Did you understand the question?
Yes, sir.
Tell me when you're ready, okay? Because then we'll move on.
Yes, sir.
Ready? Five things that a proximal 5 lumens, what does it measure or what does it do on a Swan Ganz catheter? Fitun, this one is for you, okay? I put these slides in specifically because you asked me to explain Swan Ganz. So I will now
Yes, sir.
Swan Ganz.
Yeah, thanks. Thank you.
Okay, the next 4 or 5 slides I have specifically put in because you asked me for Swan Ganz. So you will understand it.
Thank you so much.
Okay, I'll show you what is there. Okay, so let's look at this picture very carefully, okay? So one is first is the connection to the computer. So one is all the gadgets. All the wires are connected electronically to the computer. So one should be the computer connection. The second one is PA distal. The third one is proximal. The fourth one is a balloon. And the fifth one is a pacing wire. So there is one, this is the most important one. This is the one which allows you to inflate the balloon at the tip. Okay, so that's number one. So inflation of the balloon, that's the whole purpose of the catheter. So inflation of the balloon is done by this. And these two, PA proximal and PA distal, means this allows you to inject stuff before the balloon, and this allows you to inject stuff after the balloon, because you use a technique called as thermodilution, okay, where you inject cold saline and you measure the temperature change of cold saline as it goes from proximal to distal, which means it goes from the pulmonary artery into the left atrium. You measure the change in the temperature, and then you use a certain formula to calculate cardiac output. Okay, and I'll talk about it, don't worry. But just understand, so this is proximal injection, this is distal. And then you also have one extra wire which allows you to connect to a pacemaker, and it will allow you to pass a guide, a pacing wire across this to pace the heart. It will give you a connection to pace the heart. So there are 5 tips at the proximal end. One is the computer connection, one is the pacing wire connection, one is a balloon inflation, and then two more, one is for proximal injection and one is for distal measurements. Okay, now let's look at how the balloon Swan Ganz catheter goes. So this is what's happening. So here you are, you're coming through the central line, you're coming into the central line, you're passing the Swan Ganz down the SVC into the right atrium. So first, as soon as the Swan Ganz enters into the SVC, it will start to measure right atrial pressure, which is the JVP. So it will exactly measure the JVP. As it goes from the right atrial pressure across into the right ventricle, it will measure right ventricular pressure. So it will be a different graph, and I'll show you all of that. And then you monitor this. So as you move it along with the flow of the blood, it floats. So it's called as floating a swan. You float the balloon, the swan across the pulmonary valve to go into the pulmonary artery. So now it will measure the pulmonary artery pressure. So there is one tracing which will represent the JVP, which is the right atrial pressure. The next tracing will represent the right ventricular pressure. The next tracing will measure the pulmonary artery pressure. And then provided the lung has no pathology, this is all a low pressure circuit. The moment you inflate the balloon, the tip has a sensor, and the sensor is measuring this pressure, and this pressure will directly correlate with left atrial pressure, provided there is no problem in the lung. So a pulmonary artery wedge pressure is an indirect measurement of the left atrial pressure by measuring the pressure in the pulmonary artery after wedging out the proximal changes. The moment you inflate the balloon, the proximal pressure changes will be dampened. No more, this pressure will not be reflected here. And a sensor at the tip of this catheter will directly measure this pressure. And this pressure, if the lung circuit is normal and there is no pulmonary embolus or pulmonary hypertension, this pressure will indirectly represent left atrial pressure. And the whole game, the whole reason why the cardiac cycle is very important is because the left atrial pressure decides what is the filling of the patient. It's not the right atrial pressure, it's the left atrial pressure which is the most important when you're dealing with a sick patient. When you want to make sensitive changes to movements of fluid, how much fluid to give, how much fluid to hold back, whether to give inotropes or not to give inotropes, it is the left atrial pressure which guides you better than the right atrial pressure. Okay? So that is why you use a swan. Now look at how do you float a swan. So when you are floating, now I want you to draw on your book. Okay, the next picture is, I want you to draw 4 graphs. Okay, one next to the other. Start with the right atrial pressure, which will be the JVP. So draw the JVP and then move into the right ventricle and draw me what the right ventricle looks like. And you've just seen it in the cardiac cycle. You saw the right ventricular pressure in the cardiac cycle. So draw me the right ventricular pressure and then move the next step and draw me the pulmonary artery pressure. And you know the pulmonary artery pressure varies from 10 to 25. So draw me the pulmonary artery pressure. And then the last thing that you do is draw me a wedge pressure. Once you've inflated the pulmonary artery, what do you think the left atrial pressure will look like? And which essentially should be the right atrial pressure. Okay, so it's a clue I'm giving you. So I want you to draw 4 graphs, but in continuity. So draw the right atrial pressure, draw the right ventricular pressure, draw the pulmonary artery pressure, and draw me the pulmonary artery wedge pressure. And I'll explain to you how we float a catheter. Once you've drawn this, I will explain to you how you float a catheter. And give me a couple of minutes, I'll be back. Please draw this. Okay, are you ready? Hello? Yes or no?
Yes, sir. Yes, sir.
Okay, so now look at this picture and understand how we float a catheter. So whenever I am there with a sick patient in the ICU, I will take the catheter, I'll get it ready, I'll flush it, make sure everything is okay. I will have a central line in place. So you already have an access. So the central line is put in by Seldinger's technique. And then once I have got the central line in place, I will take the Swan Ganz catheter and I'll put it into the central line in the neck. And I am looking at the graph. So the first graph that I will get, as soon as the sensor is at the tip of the catheter. So as soon as the sensor enters into the SVC or the right atrium, you will get the JVP. Okay, it's exactly the JVP that you get. You pass the catheter gently down the right atrium and push it into the RV. It follows the track of the flow of the blood and goes into the RV. I am looking at the screen. I am not looking. This is a blind procedure. I cannot see what's happening to the tip, but what I can see is a sensor pressure change on the screen. So the moment it passes across the tricuspid valve, your change will be a ventricular pattern. Okay, so the dimensions will go from 0 to 25. Okay, whereas here it was just the JVP. The moment you get a diastolic and systolic rise. So you can see the diastolic and systolic rise on the catheter. The moment you see this diastolic and systolic rise, then you know you're in the right ventricle. At this stage, I will take saline and inject into the balloon. So now the balloon will start to float in the blood. It will float, it will rise and float in the blood at the top of the blood in the right ventricle. And then with the cardiac cycle, I will let it float into the pulmonary artery. So it's technically, when you push it in, it goes in straight. It can go into the RA straight, no problems. It can go into the RV straight, no problems. But to enter into the pulmonary artery, you have to inflate the balloon and let it float into the pulmonary artery across the pulmonary valve. And then when it comes into the pulmonary artery, you know you are in the pulmonary artery when the tracing changes, the tip of the sensor changes and shows you a pulmonary artery tracing. Okay, so then you get the tracing of 10 to 25. So this is a different thing. This is pulmonary artery now. You know that. And then when you keep floating it, then it will go and wedge against the smallest pulmonary artery. The diameter, it will wedge against whatever is the edge of the diameter. And the moment it wedges, then you will get a trace, which will be just like a JVP, but this trace is the pulmonary artery wedge pressure, which is indirectly representing the left atrial pressure. So when you float a Swans, you have to actually look at the tracing and you have to keep floating. Going across into the right ventricle, you will see this massive rise and fall. Then you inflate the pulmonary. Every time you want to float, you have to inflate the balloon, and the balloon will then float into the pulmonary artery across the right ventricle because the direction changes. And then you will see the pulmonary artery flow till you wedge against when the diameter of the balloon will not allow it to go any further. And then you will see this. And the moment you see this, you do whatever you have to do, but you must deflate the balloon. If you keep the balloon inflated, you will damage the pulmonary artery and cause a bleeding. You don't want to do it. So you inflate the balloon only when you want to check the pulmonary artery pressure. All other times you have to keep it deflated. Many a times it may not go in the correct direction and it may get a bit haywire. So you have to withdraw the Swans back. You have to withdraw the PA catheter back and restart. So you withdraw back into the right atrium, or many a times you withdraw back only into the right ventricle. But when you withdraw, you must deflate the balloon while withdrawing. You don't want the balloon to hit against the valve and cause a damage to the valve. So you withdraw the balloon. Once you come back, you will see this tracing, and then you will see this tracing. Once you know this tracing, you know you're in the right ventricle. You re-inflate the balloon and let it float into the pulmonary artery. The moment it floats into the pulmonary artery, the tracing will change, and then it will go and wedge against something, and you know you're there, and you just release it at that stage, and then set everything up, fix, don't keep the balloon inflated, fix your catheter, fix everything else, make sure you are in the correct position, and leave the swans in that position. And then you use the calculation of the pulmonary artery wedge pressure, and you use the calculation of the cardiac output and the cardiac index to change your monitoring. So in a very sick patient, what you do is you want to increase the inotropes, you want to decrease the inotropes, you want to give fluid, you want to give dopamine, you want to give adrenaline, you want to give noradrenaline. That decision of what inotrope to give, how much to give, how much to increase depends on the wedge pressure and depends on the calculation of the cardiac output and cardiac index. So after you have made the change, you wait for 1 or 2 hours, or not 1 or 2 hours, but at least half an hour, 20 minutes, 25 minutes for your change to take effect. And then you measure the pulmonary artery wedge pressure again. And then once you measure it again, you will know that your myocardium is starting to improve. So your cardiac index is the key indicator. So if you've got a cardiac index of 2 or 1.5, then you start doing manipulations, you increase the inotropes, you do whatever you have to do. And then once the inotropes go in and the heart starts to beat a bit better, then you redo the fix, the thermodilution technique and measure the cardiac index again. So it gives you like a measurement of cardiac index. And then you will see that there is an improvement in the cardiac index. So which gives you an idea that the inotropes that you have given to this patient are now starting to make the myocardium beat a bit better. Did you understand this explanation? So we have spent nights and nights and nights in the ICU with a very sick patient, trying to float the PA catheter and measuring it every hour, 2 hours. But you never keep it inflated. You just want to keep it there, measure what you have to do. And I'll tell you in a minute, I'm just going to come to that in a minute, and you'll understand what I'm talking about. So pulmonary capillary wedge pressure reflects the left atrial pressure as the resistance in the pulmonary vein is low. A flotation balloon is passed through the right heart into the pulmonary artery. Inflation of the balloon excludes the flow from the right side of the heart, allowing a fluid bridge to complete the connection to the left atrium. The pressure at the tip of the catheter equates to that in the left atrium. The balloon is deflated between readings to avoid pulmonary infarction because you're obviously stopping blood flow. Normal pulmonary artery occlusion pressure is 6 to 12 millimeters of mercury. You keep it below 15 millimeters of mercury because you want to reduce the risk of pulmonary edema. And the main advantage of a Swan Ganz is you use it to measure cardiac output and cardiac index. So this is what happens. You come into the right atrium. When you're in the right, let me show it to you on this screen. So the right atrium will give you a tracing down here, JVP. Then you advance it into the right ventricle. The right ventricle will give you a tracing of the right ventricle. Then you float the catheter C into the pulmonary artery, and that will give you a tracing of the pulmonary artery. And then you wedge it. And when you wedge it, you get a tracing of the left ventricle. Okay. So this is quite important to understand. Now, I'll just finish a couple more slides before I stop. So coronary blood flow is about 250 ml at rest, rises to 1 liter on exercise. This was not supposed to be the next slide, but it's okay. I'll just finish it. So coronary blood flow is reduced during systole, especially during isovolumetric contraction due to compression of the intramyocardial arteries. Obviously, when the heart is contracting, the intramyocardial arteries are reduced. So that's why that coronary pressure reduces. And so coronary blood flow occurs mainly during diastole. This is something that you have to understand. These slides were supposed to be earlier when I was talking about coronary circulation. I'm sorry they got, so let me just skip this slide and come to the cardiac output. So cardiac output is the volume of blood ejected by the heart in 1 minute. It may increase to 3 to 4 folds in strenuous exercise. The measurement of cardiac output is stroke volume into heart rate. Just 1 second. No, I just want to come to a further slide when I'm talking about this. Just 1 minute. Sorry about that. I'll go through the cardiac outputs again for you, but really what I want you to understand is this, that cardiac output measurement is done by 4 methods: fixed method, thermodilution, dye dilution, and Doppler ultrasound. Okay. Now, how do you do that? What you do is oxygen consumption by the whole body is measured for about 15 minutes. During this phase, blood samples are taken from a systemic artery and pulmonary artery. So, you know, the Swan Ganz can allow you to get into the pulmonary artery and get a blood sample there. Okay. The fixed method uses this combination. So it looks at oxygen consumption by the body into arterial oxygenation minus mixed venous oxygenation. And then it calculates the whole thing. This is a calculator. You don't have to calculate. The computer will calculate it for you. The important thing in a Swan Ganz is the thermodilution technique. This is what I wanted to show you. So what happens is, in a Swan Ganz, you give a bolus of ice cold saline. Okay, ice cold dextrose, 5% dextrose. You rapidly inject into the right atrium via the proximal lumen of the pulmonary artery catheter. Okay, so the Swan Ganz is in place. You've got the Swan Ganz floating into the pulmonary artery, and you inject the ice cold 5% dextrose. The dextrose mixes with the blood and causes a fall in the temperature, which is recorded by a thermistor at the catheter tip of the pulmonary artery. So the change in the temperature of the saline from the right atrium to the pulmonary artery is measured by the catheter. Once you have got the change, the drop in the temperature from right atrium to the pulmonary artery, the computer will automatically derive the cardiac output. And the cardiac output then you get a number on the computer saying what is the cardiac output of this patient, because it already is calculating stroke volume and PVR and the ventricular stroke work. Okay. So did this make sense what I just said? This is how you use a Swan Ganz. So when you float a Swan Ganz, you actually inject saline, a cold saline or 5% dextrose. You inject, and there is a reading of the temperature before, and then there's a reading of the temperature as the cold saline passes into the PA. And the difference in the temperature reading gives you how well the ventricle is contracting. So this drop in the this rise in the temperature is actually calculated by the computer, and it gives you cardiac output. So this is how you use a Swan Ganz catheter to calculate cardiac output measurement. And then once you've done a cardiac output measurement, then it is computed with height and weight, and then you get cardiac index. So it gives you an indirect measurement of cardiac index. Did this make sense to you guys or no? Coming back to Swans, I don't want to go ahead. So this is quite... Hello, did you understand this?
Yes, sir.
Yes, sir. Yes, sir.
Is it very clear,
Yes,
the
sir.
concept of how Swan Ganz work?
Yes, sir. Yes, sir.
Yeah?
Yes, it is.
I think the time is 7 o'clock, and this is a very, very complicated topic. I'm going to stop here. As you can see, maybe you can't see it, but I have about 250 slides. And at the moment, we are only on slide number 54. So there's a lot of work to be done in this. So we're going to stop this lecture here. I'm going to stop recording first. Where is the recording? stop share. Let me come back here and let me stop the recording.